account for around 18 to 85% of total case of lung cancers. Around 15% of patients, they are non-smoker. And the median age of diagnosis around 70 years. But India, we see that median age is around 55 to 60 years of age. And the most cancer, they came with the distant mates. Around my practice, I see around 75% patient came with the distant mates. And targeted agents, we know that the increase the survival in the these patients. Like initially is about 5.1 months in the supportive care patients to 31.8 months in the targeted era. So there is quite evolution in the treatment in the non-small carcinoma lung. Next slide. So the landscape, we see the early 80s and mid 90s. Only there is two types of cancer, like non-small cell or small cell carcinoma lung. In non-small cell, only chemotherapy, Pecli, JAM, or pemetrexed. And in small cell, etoposide cisplatin. From mid 90s, there is evolution in the histopathology of the non-small cell carcinoma. Now we divided adenocarcinoma and squamous cell carcinoma and large cell carcinoma. So there is evolution in the histopathology. And from late 2000s, there is a quite remarkable evolution in the treatment part, like EGFR, then ALK, then ROS1, then PDL1. So now we are seeing lots of molecules in the non-small cell lung. Next slide. I already spoke that the in targeted era, the 5-year survival is increased in this patient, like the 31.8 months in the MOS now in targeted era patients, and 5.1 in the supportive care patients. So there is lots of improvement in the OS in these patients. And the molecular profiling of this patient is around, mostly they are the unknown mutations. They are not actionable mutations. 15% they are fully wild type of tumors. And the EGFR is 11%, but in India we see around 30% they are the EGFR positive. KRAS is 29%, HER2 1%, BRAF 2%, ALK is 5%, but mostly they are the non-actionable mutations in the NSCLC. Next slide. So now I discuss the study of IMFR 110, 130, and 150. There are some questions related to study, like is the atezolizumab monotherapy is a superior to chemotherapy in PD-11 high adenocarcinoma patients. IMFR 30 is the steroid-sparing chemotherapy with atezolizumab is superior to the chemotherapy alone. And IMFR 150 is the addition of atezolizumab to chemotherapy plus bevacizumab in high PD-11 in non-squamous or non-squamous cell cancers. So next slide. So first is the IMFR 110 study. Is the squamous and non-squamous NSCLC. Atezolizumab monotherapy compared with the platinum agent cisplatin or carboplatin in NSCLC. Next slide. So it's a randomized trial, stage 4 non-squamous or squamous histology, PD-11 selected patients, EGFR ALK negative, and stratification factors are 6, echo histology, PD-11 by ISC expression. And they are randomized in atezolizumab monotherapy versus chemotherapy in a non-squamous is a PEMI, Texas cis or carbo. In squamous is a JAM cis or carbo. In maintenance, in pemetrexed in the non-squamous and base supporting in the squamous, and atezolizumab is the maintenance therapy. And they divided according to PD-11 staining, like more than 1% or 1 to 5% and 10% IC over TC is more than 1%, 5 to 50%, more than 50%. Next slide. So the prevalence of PD-11 expression is equal to all the group, like 38.6% high PD-11 score. Both chemo and atezolizumab group had a equal PD-11 status, like in the TC more than 5% is same and more than 1% is same. So there is equal distribution among all the group. Next slide. And the baseline criteria are the same between two groups, like age, male, white, Asian, never used tobacco, non-squamous histology are the equally distributed among all the groups. Next slide. So now in this slide, we see that there is always benefit in the atezolizumab monotherapy arm compared to the chemotherapy arm. 31.1 months in the chemotherapy arm is 20.2 months in the monotherapy atezolizumab arm. And the 6 months OE is 76.3% in the monotherapy and 70.1 in the chemo arm. And 12 months OE is 84.9 in the atezolizumab arm, and 50.9 is the and the OS benefit is seen in all subgroup except the never smoker, never used tobacco group. Otherwise, all the or age factor, female, man, ECOG status, all favorable to atezolizumab compared to the chemotherapy. Next slide. And mostly a third of patient in the control arm receive subsequent cancer chemotherapy, immunotherapy. And we see that there is a immunotherapy is around 28.9% they received in the chemotherapy arm. Next slide. There is clinical PFS benefit in the high PD-L1 expression arm. Like there is a 8.1 months PFS in the atezolizumab arm compared to the 5 months in the chemo arm. And hazard ratio is around 0.62. Next slide. And confirmed ORR is also better in the atezolizumab compared to the chemotherapy arm. Now 38.3% in the atezolizumab arm compared to the 28.6% in the chemo arm. Next slide. And the safety profile is mostly equal in the both arm. Like the immunotherapy, immune mediated side effects are more in the atezolizumab arm compared to chemotherapy arm, but it's well tolerated monotherapy compared to chemotherapy, and there is no major concern except pruritus or hypothyroidism. Next slide. Like in this slide, the anemia, nausea, vomiting, constipation, thrombocytopenia, or decreased platelet count are they common in the chemotherapy arm. In the immunotherapy arm, the increased AST, pruritus, hypothyroidism, they are common in the immunotherapy arm. Next slide. So in the summary, atezolizumab monotherapy is a promising first-line treatment option in patients with PD-L1 high NSCLC. Is a positive study which demonstrated a significant and clinically meaningful improvement in OS in high PD-L1 expression population versus platinum-based chemotherapy. The hazard ratio 0.59 is comparable to the other immunotherapy like checkmate in the checkmate trial. So it's comparable to other immunotherapy. The safety profile atezolizumab is acceptable, favorable safety profile is there. No new unexpected safety signals were identified. Atezolizumab had a favorable safety profile compared to the chemotherapy, and patient treated with atezolizumab had a longer treated exposure than patient treated with the chemotherapy. The next slide. Next slide. Now I discuss the IM4 150 trial. Is a phase 3 study of atezolizumab plus chemotherapy and bevacizumab in first line advanced non-squamous non-small cell carcinoma lung. Next slide. So is a phase 3 study first line atezolizumab plus chemotherapy and bevacizumab in non-squamous NSCLC. So preclinical questions: does the addition of atezolizumab to chemotherapy plus bevacizumab have some clinical benefit, or is there we can replace the bevacizumab with the atezolizumab in these patients, and the atezolizumab carboplatin bevacizumab and the pemetrexed or bevacizumab carboplatin pemetrexed these are the incision 1 category indications recommendation for the non-squamous cell carcinoma lung. So stage 4 NSCLC chemotherapy naive statistic factor 6 PD-L1 IC expressions and liver mets. So they are stratified in the 3 group, like in liver mets group, the EGFR positive which treated with prior TKI therapy, and third is a bulky disease. So they are evaluated all these stratification, and they come to some conclusion. And the first arm is the atezolizumab carboplatin plus paclitaxel. Second arm is the atezolizumab carboplatin paclitaxel plus bevacizumab. And third arm is the carboplatin paclitaxel and bevacizumab as a maintenance age routine, like atezolizumab in the single age atezolizumab and atezolizumab bevacizumab in the bevacizumab arm. Next slide. There are some rationale that why we use atezolizumab plus bevacizumab in these patients. So there are some mechanism like bevacizumab inhibits VEGF mediated suppression of dendritic cell maturation, enabling efficient priming and activation of T cell responses. Chemotherapy induced immunogenic cell death can trigger the release of tumor antigens. So there are various hypotheses by which we can add there's additive effect of atezolizumab plus bevacizumab. I will not go into details of this slide. Next slide. So baseline characteristics are the well balanced between the two groups. Like 14% of patients had liver metastasis at baseline, which where stratification factor in IF 50 and stratified between equally between all three groups. 10% of patients had EGFR mutation which treated private TKI therapy. And they are approximate 50-50 split between PD-L1 positive and negative patients. So there is well balanced between all three groups. Next slide. So there is significant OS benefit with the addition of atezolizumab to intent to treat population of wild tumor NSCLC. Like median OS is 14.7 months in the chemo plus bevacizumab is around 19.5 months in the atezolizumab arm, and the hazard ratio is around 0.80. And there's 12 months, 18 months, and 24 months OS is better in the arm B compared to the arm A. The next slide. The improvement, and we are seeing that in all the population, interpreted population, I PD-L1 or a PD-L1 low group or PD-L1 negative group, there is a clear-cut benefit of addition of atezolizumab to chemotherapy plus bevacizumab, like 58% in the interpreted population compared to the other arm, and a median duration of response is around 11.5 months in the atezolizumab arm. Same with high expression, there is 69% benefit overall compared to other group, and they are significant and comparable to other immunotherapy. Same with PD-L1 low and the PD-L1 negative tumors. So median DOR is good in arm B compared to the arm A and arm C. Next slide. Same side, there always benefits observed across all PD-L1 subgroups like PD-L1 high, low, or negative. There's clear benefit in all these three groups. PD-L1 high patient are the most benefit. Obviously, uh, because of high score, there's good benefit with the atezolizumab. Even PD-L1 low and PD-L1 negative group also show good OS benefit. Next slide. Now they compare this trial in the EGFR patient after EGFR TKI. Next slide. So, like integrated population, wild tumor, then they take EGFR mutation or ALK mutation, rearrangement patients, treat with EGFR therapy, and then on the progression, they stratified and the randomized patient with chemotherapy, bevacizumab or atezolizumab plus bevacizumab. Next slide. So the clinically significant PFS benefit observed in arm B compared to the arm and arm C. Like the PFS curve separated after 6 months in the arm B compared to arm C. So median OS is PFS is around 8.1 months in the arm C compared to the around 8.7 months, 9.7 months in the arm C. and the hazard ratio is 0.59. So there is clinical benefit of the atezolizumab plus chemotherapy plus bevacizumab in EGFR TKI progress patients. Next slide. Similarly, arm B had a OS benefit compared to the arm C. Like we are seeing in this slide, there is 4 months of OS in arm B compared to the arm C. And the hazard ratio is 0.60. So it's quite significant that TKI patient, is a positive patient after TKI, we can use option of the atezolizumab plus bevacizumab plus chemotherapy. Next slide. The OR also the ORR response increased from 42% to 71%. So it's quite significant response. Also duration of response also good in the atezolizumab, like 11.1 months in the atezolizumab arm and 4.7 in the bevacizumab arm. Next slide. Also some they also divided in the liver mets patient. Next slide. There is also a clinical meaningful PFS benefit observed in the arm B versus arm C in patient with liver metastasis at the baseline. Like it's a median is 5.4 months in the chemo plus bevacizumab arm compared to the 8.2 months in the chemo plus bevacizumab plus atezolizumab arm. And a patient with liver metastasis a negative prognostic factor. Still, it can be okay. So, in conclusion, next slide. Next slide. Next slide. So there is additional bevacizumab to atezolizumab plus chemotherapy provide overall response rate and duration response in patient with liver metastasis. Next slide. Also, the patients with bulky disease had a good OS benefit with the immunotherapy. Next slide. Like high disease burden is a more than third quartile or more than 2 million metastasis size. If they more than 2 sites or mets, they score bulky disease. If less than 2 mets, this called metastasis size is called non-bulky disease. Next slide. And in this slide, we said that the arm B is a meaningful and significant OS and PFS benefit compared to the arm C. So in bulky disease or non-bulky disease, the atezolizumab plus bevacizumab chemotherapy had significant benefit compared to B plus chemotherapy. Next slide. Next slide. So the safety profile is comparable to the other group. Compared to the other group, the obviously there's immune-mediated side effects more with the immunotherapy arm compared to the bevacizumab. But the overall the safety profile is good in the immunotherapy arm. Next slide. So in conclusion, IM550 is a positive study in the first line non-squamous NSCLC with statistically significant and clinically meaningful improvement in both co-primary endpoints OS and PFS for the immunotherapy arm. Clinical benefits observed in key subgroups of patients with EGFR genetic alteration or liver metastasis or at baseline or the bulky disease. Atezolizumab in combination with chemotherapy plus minus bevacizumab is a well-tolerated and safety profile is consistent with the no safety risk. Additional patient categories beyond PD-11 expression may be considered when making chemoimmunotherapy treatment decision for non-squamous NSCLC patients. Next slide. So it's a phase 3 randomized trial. The first immunotherapy combination to demonstrate meaningful OS in EGFR positive patients and patients with liver mets. And PFS benefit is double, around 38% with the immunotherapy arm compared to 20% Avastin plus carbo plus Pecli arm. Next slide. So intermediate population, the atezolizumab arm is at 90.8 months benefit is in the compared to 14.9 months in the bevacizumab arm. EGFR mutation is at 29.4 months is quite significant, and only immunotherapy which have some promising role in EGFR mutation patients. And liver metastasis has a higher 30.3 months compared to 9.4 months. So higher overall response to atezolizumab plus Bevacizumab plus carbex. So thanks. I conclude my slide here.
Thank you, Dr. Ashish, for enlightening us about the